So are you happy to make a start?
Mm-hmm.
Yeah.
Excellent. Triple check I'm in view. So welcome. I'm joined in Lincoln by Richard Pell, Cormac Ryan and Lorimer Mosley at the launch of the Flippin Pain Initiative, a community pain initiative that Richard will tell us more about coming up. But I'd love for you to all introduce yourselves a little bit further, if that's okay. I don't know if you want to start, Richard.
Yes, my name is Richard Pell. I'm Head of NHS Service Development with Connect Health, and part of my role is campaign lead for Flippin Pain.
I'm Cormac Ryan. I'm Professor of Clinical Rehabilitation at Teesside University, and I'm also the Community Pain Champion for the Flippin Pain campaign.
And I'm Lorimer Mosley, the third of the three of us. I'm a pain scientist, educator from Australia, helping out with what's going on here.
Brilliant. I'm delighted to be here with the three of you. Thank you very much for your time. Richard, I know you spent a lot of time organising this event, and then two pain experts in your field as well, so thank you. Richard, can you tell us a bit about what's been going on here in Lincolnshire over the past few months and what the vision is?
Yeah, I can. So I think we probably need to go back probably a couple of years, a year or two, to the clinical commission groups in Lincolnshire collectively came together and decided to do something pretty significant and pretty ballsy in terms of providing pain management care. So that they collectively came together, 4 clinical commissioning groups, and decided to take a really bold step to decommission their previous services and recommission a single community pain management service. And that amounted to a lot of different things, but one thing it did was represented a significant and in some ways quite abrupt step change in clinical culture when it comes to pain management. So historically in Lincolnshire, prior to April of last year, access to pain management was all hospital based. There was no community service. The vast majority of service provision was consultants and anaesthetists led, and was almost exclusively access to interventions, injections and medicines. There was, of community pain management services operating in Lincolnshire, there was one physiotherapist, not a single occupational therapist. There wasn't access to psychology within a pain management service. So it wasn't aligned with best practice guidelines, it's fair to say. As part of Connect's bid to deliver that service, to be the community pain management provider, we looked at that, to coin one of Lorimer's terms, I think, or the Pain Revolution's terms, the need for a grass tops and grassroots approach. So bringing in a new service, a single point of access community service that was as broad, holistic, aligned with best practice guidance, was the grass tops. That's through your clinical practice, touching the people coming into the service, accessing pain management services. But then the grassroots stuff is really where we get into what we're talking about today, which is around raising awareness and understanding at community level, at local population level. So rather than just touching and influencing those people as they come into a service, supporting that significant step change, cultural change, by getting out into the communities and sort of spreading the word, spreading some of the right messages.
Wow. Is it the first kind of project like this that you're aware of in the UK?
It is. Doesn't mean to say it's not happening, but we haven't, in the time we've been doing this, we haven't become aware of that. There are lots of, as a community healthcare provider across pain and MSK, there are a lot of things going on about stakeholder engagement and community engagement, but the size and the type and the nature of this campaign, the focus around pain science or understanding of contemporary pain science, the full-on public health campaign approach is something that we believe is novel in the UK, at least.
Yeah. This is something that you'll be familiar with, Lorimer, because we're kind of basing, I suppose, the project on the Pain Revolution service that you were part of. How do you see the similarities and the differences, and is that an effective way that you found in Australia of spreading this message?
So there's a lot of similarities, I guess, intentionally, because we've been talking about it for a long time, and I guess we've got a few years' experience in that sort of community-targeted education. I think the thing, even listening to your account of that, Richard, I was thinking, we now know persistent pain is a public health problem. It just makes sense to have a public health strategy, and it's remarkable actually that it's novel. I was thinking that, it's quite remarkable that we've known this for a long time and yet it's still novel. Our experiences in Australia were really driven by an observation of a couple of things. One is that we've known for quite a long time what the best evidence-based approaches to prevent and overcome persistent pain are, and the clinical guidelines for 20 years have not really changed much. They focus around education and understanding, active and psychological therapies and self-management skills, and they haven't really changed. But over that time, the type of care that people are receiving has changed away from the guidelines, which is remarkable. And I remember thinking, observing that and thinking, we need another approach. The difference, some of the differences that we're facing is that we don't have the same level of control over the grass tops. Pain Revolution is a grassroots and grass tops initiative, but what we're trying to do in Australia is target consumer expectations and community norms about what to do when you have pain, what to do when you have an acute episode, what you can do about it when you have a persistent episode. And we're focusing on rural and regional Australia, where the health professionals are so connected to their community, but they're generalists, and they don't get the same opportunities to develop their skills and their expertise. So what we're doing there is getting keen, rurally based health professionals, training them, supporting them, and linking them in with a growing network of people with high level pain understanding and best practice. So the similarities are this sort of two-tier approach. The differences are that we're going rural and regional, it's big geography, low numbers. And I know that Lincolnshire here is a reasonably big area with a reasonably low density compared to the rest of the UK, that's my understanding, but it would still be a much greater density than the areas where population density, where we're dealing. But actually one of the things that I'm loving about this relationship with the Flippin Pain project is how much we're learning to be able to integrate into what we're implementing in Australia as well. It's a very, I feel like it's very collaborative.
Yeah, works both ways.
Yeah, exactly.
Brilliant, and it does, it makes sense, as you say, this is a global problem, certainly a nationwide problem that we have here. A healthcare system that's swamped, it makes sense to take it out into the grassroots, as you say. Is that your experience as well, Cormac? You've been involved in public education of pain through this too. What do you find as us physios listening are the best ways to address this within the community?
I think it's a hard sell within the community. For 50 years within the sort of scientific community, we've had a decent understanding that pain is reasonably complex, and it is influenced by so many factors beyond the body. But that really hasn't, that perception of tissue injury results is the cause of pain and that is it. That perception hasn't changed within public understanding. And I would say that it's a huge failing of the scientific community that it hasn't shifted at all. And I think the movements such as this, such as Pain Revolution and Flippin Pain, are important steps forward to redressing that balance and beginning to shift that community understanding in the right way. How do we do it? Well, of course there are things like this, these public health campaigns, but I think that the physio on the ground should really, to steal another initiative, make every contact count. Every time they interact with a patient, regardless of kind of why they're in, I would see as an opportunity to try and edge them, nudge them more towards a more scientifically informed understanding of pain, because I think that means should they develop pain, they'll manage it better. I think they'll recover quicker, and if they have pain at the time, the same is true. So I would say make every contact count, but do it with empathy. I think that's pretty key as well. There is a huge risk when trying to address some of the misconceptions that you can come across in a way that is not really empathic, you know, and it is almost seen as cold and non-caring. Well, Flippin' pain should really be about flipping that, about seeing that actually taking the time to carefully address these misconceptions is empathic in itself and should be encouraged and seen along those lines. So yeah, make every contact count, but do it empathically.
Brilliant. And we talked, there was a question raised in the event itself where there was a person of school age, high school age, who said, how do I get other people to understand my pain? This is hard, and I think both of you gave really good answers to that, so I wanted to bring it up. We're almost making the person an advocate for pain education themselves. And I just wondered if we could revisit that, and if you could share some of your wisdom on that again, with regards to how we empower someone to empower themselves, as it were.
Yeah, that was a terrifically courageous person, wasn't it?
Yeah.
My response to that is to take that opportunity. I almost feel like there's a responsibility that we all have when we learn something, particularly if it's potentially transformative, and that is to be honest about conveying that knowledge, even when that might be an uncomfortable situation. And I do see, in fact, sort of relevant to your first question, Felicity, that some of the things that we've learned in that public health education space is to really value the stories and the wisdom of recovering persistent pain, people with persistent pain who are recovering from that and are on the actual journey that we're hoping to help them on. And this young person clearly is on that journey. It's clearly a long and difficult journey. But my response was, we spent some time researching key phrases that people can use, and the sort of phrases that come in are things like, I've got an overprotective pain system at the moment, or I currently have an overprotective pain system. I'm learning a lot about how I can turn this around, and there's a lot of contributions to that. Do you want me to explain it to you? It's actually quite amazing, and you know, we actually have people challenged by pain practicing those sort of turns of phrase, things like, it's actually really amazing to try and bring the recipient into some curiosity. You know, well, how is it amazing? Wow. You know, pain is about so much stuff, and my immune system, it might be a particular situation, my immune system's contributing to this. But as far as I understand, things are adaptable, and I'm going to be training this for a while, but I'm hopeful and I'm watching things slowly improve. So people actually try, practice those phrases. So my angle on that question was very much about the role that recovering people have in educating their community, and that community might be their family, their friends, their wider community. Become a champion. It's a powerful voice. That was the main thrust of my response. Your response, I seem to remember, was really focusing again on that.
Empathy. Yeah,
it's a big thing for you, isn't it?
It is, absolutely. I think it's just so important. So I drew a little first on some of the evidence that's out there in terms of the importance of empathy in recovery, and there's some really neat evidence that demonstrates, in terms of what can predict recovery, the amount of empathy that a person perceives or a patient perceives is one of the things that can predict recovery. And I think that means it's so important for us as clinicians to deliver this these messages empathically. But in addition, her question was about connecting with her family and friends, and that's where Flippin' Pain comes in, and this sort of public health campaign, because we're not just trying to sort of connect with that lady, we're trying to connect with her friends and her family, so as they understand a little bit more about pain. They're nudged in that direction, because if they are, then in their interactions with her, one would hope that will trickle down and make them a little bit more informed and empathic in their sort of questionings and relationships. So I think it's that public health message, making sure we don't just target people with pain, because that's not what a public health campaign should be about. It's about everyone.
Yeah, that makes sense. If you have persistent pain, I imagine, and what we hear from patients, a lot of the suffering of that comes from the lack of empathy or lack of understanding from the rest of society, and the lack of understanding about how it works. So no, that makes a lot of sense.
I mean, how many of our patients, when they talk a little bit about their pain, they say it's not like breaking your arm and having a plaster on that everyone can see. It's a hidden thing, and I think that perhaps reflects that element that they don't feel that empathy from their fellow man, as it were. And I think that might be underpinned by the public perception of chronic pain and not appreciating the science underpinning it.
So clearly hugely important work. How do you deal with the challenges of, you've got a room full of people of different educational backgrounds, different pain backgrounds. We all know as listeners what it's like to deal with someone one-on-one, and there's challenges in prizing apart, picking apart the story and listening there. How do you both manage that, having done this before?
I'm happy to respond to that first. We're quite heavily involved in helping health professionals, many of them are physios, with that really challenging task of bringing understanding to a diverse group of people in front of them. And maybe that's a diverse group of people who are challenged by pain, and maybe it's a diverse group of people who are challenged by treating people with pain. And I actually think, I'm not a physiophilic person, right? But I do think that physiotherapists tend to have a really good skill set for this, because I think they do tend to have a degree of empathy, they're good communicators, and they're clever. And I think these are three critical components. I think you need to have a strong content knowledge, and you can't fake that. You really can't. And that's where you have to put in the work. You got to learn the material, because learning the script is good until you get this sort of response from a patient who looks away, or you get the off posture, or you get a question, and then you fall off the script. And actually, we've got data that show that even people who are delivering a contemporary pain science message, when they're feeling vulnerable, they switch to a biomedical understanding. We've got data that show that. So one of our roles in helping people is to make sure their content knowledge is solid enough that they never slip off onto an outdated, really contradictory understanding of the problem.
But don't beat yourself up when you do. I think as a clinician, it's a really challenging thing, and I'd be the first to admit that occasionally I do slip, and I see myself doing it, and I'm thinking, what am I doing? Try and pull back, and I just gotta say, okay, well look, next time I'll try not to slip. But it's tricky.
Actually, I think we might be going off topic, but I actually think that's a really important message for any clinician, whether it's in a one-on-one or any other thing, that this is such a challenging pivot. It really is a challenging pivot. That we have a tendency, I think, as health professionals, when something goes wrong, or more to the point, when this person in front of us or people in front of us are choosing a behaviour that we think that is bad for them, despite our best efforts. That feels a bit, you get frustrated and you start saying it's a heart syncopation, and we're putting all that responsibility on them, right? And I really like this idea of if we shift our key performance indicators from the person in front of us or the people in front of us doing a certain thing, I know that's an intuitive, sensible KPI, but if we could shift it from that to we are doing everything in our control to be the best clinician and human we can be. And then that becomes the appraiser, and we're committed to learning from situations that go wrong. I mean, personally, when that shift started happening for me, it was liberating because I stopped feeling so guilty when I was not getting great outcomes. But also my outcomes started to improve, I think, because if that's your marker, did I do my best to understand that, to help this person understand that, or this group of people understand? If the answer is yes, great. Even if it wasn't ideal, the next question is, next time, how do I do that better? Or how do I avoid that problem? And we're learning, and that's our responsibility, I think, to be doing that. I've gone off topic a bit with that, but I do feel quite strongly.
I can imagine huge amounts of physios thinking, oh, thank goodness, Laura Mosley and Cormac Ryan have these Friday afternoon slips into, okay.
The occasional Tuesday as well.
So no, that's useful, thank you. There was, just picking up on bits of that as well, there was a bit that you addressed early on. You may be thinking, you said in front of the audience, this doesn't apply to me. And I had a lady come up to me at the end and she said, before you said that, she was thinking, this doesn't apply to me. And that really stopped her in her tracks, and she thought, oh, okay, maybe this does. Which I thought, yeah, powerful. Have you found that from experience that's useful to say, look, everyone feels like this? But
yeah, thanks for that question, Felicity, because it lets me talk about my favourite thing at the moment. And that is that this reconceptualisation, the public understanding and the health professional understanding, I feel like it's not about us educating. That's not the key. The key is about people learning things. And I'm convinced that learning is an active event, and we have to put a lot of effort into ensuring the action of the learner. And so I use those sort of things to make sure they are always confronted, actually, with data and or with a reflection. So the other things you might have noticed, me saying, just reflect on when you look at that. Reflect where do you fit? And you might look at that and think, I don't fit anywhere, but I bet you can find yourself. Now do it. And what I'm thinking there is, how do I get this person or these people active in this experience? And I think that's one aspect of the whole sort of pain education, explain pain, whatever stuff, that I think many got wrong. And we were talking about this. This is another opportunity for me to apologise for my role in that, because I do feel like I was naive in interpreting the early randomised controlled trials. I thought we designed them really well. I think we did design them really well. But what our data, as they've built over 20 years, really show us is there's a whole bunch of stuff wrapped up into empowering someone to learn and enabling them to learn, and they have to do it. And I'm much more bold than I was in those, and you would have noticed in that situation with a group of community members. You've noticed that the message is simplified and it's a bit more targeted. Other people have noticed that I'm a bit more confrontational. And that reflects my belief system about how should this work, my understanding of the science, my own personal context. I've got a bit of credibility, so you can push that a bit more. So there's lots of things tied up in it, but I do like that trick of saying and reminding people. You might think there that this is not applicable to you, and you're right, so people relax, if you're not a human. And then you jolt, and the jolt is useful, because the jolt, and sometimes in different contexts, if we had more time, I'd say, and have a look, did you jolt? Did something jolt? Did you want to protect yourself? Did you feel yourself fading out? Oh, that's good, because that's the first part of you learning something. So I'm really excited about those developments in that sort of pain education field. Anyway, I jumped on that because I love it.
Yeah, excellent, excellent. And we did talk about how you talked about key messages there, which I imagine you do have to decide on. You've got a select amount of time. You've got people who've never been delivered this kind of message before. What would you say are key messages if we do have physios listen who deliver community events? What are your key messages? And Richard, I know you've been involved in these ones as well.
Yeah, so we've arrived at 6 key messages. You're testing me now because we've only just decided on them, so I'm doing from memory. So we have persistent pain is common and can affect anyone. Hurt doesn't necessarily equal harm or injury. Everything matters when it comes to persistent pain, which is a blatant lift and shift from Lorimer's Pain Revolution key messages. Medicines and injections may not always be the answer, paraphrasing perhaps. Understanding could be the key, and recovery is possible. Another plagiarism from Pain Revolution. But in arriving at that choice of key messages and the wording, which I probably slipped because they're quite new to us, and speaking with Lorimer and Cormac, and in addition to the clinicians, speaking to a lot of people with marketing, PR, communication expertise, has been the biggest learning experience and challenge so far for me with this campaign, which I found completely fascinating, which is we sometimes get caught as clinicians in this sort of echo chamber or this obsession around the semantics, and sometimes there's even good evidence to suggest why the semantics is so important, but sometimes we can do that to the detriment of coming up with messages that are understandable or that capture the attention of public consciousness. And in arriving at those messages, what we've done a lot of, and I expect Lorimer's done some similar stuff, is I've seen myself as one of a group of people in the middle, where I might have my marketeers on one side, if that's a word, who want a message that is as spectacularised as possible so that the local press will put it out there. They want to maximise reach, don't they? But arguably would be willing to do so to compromise some of the clinical validity or the accuracy of the message. But on the other end of the spectrum, I think we've probably all been part of, in the past, at least I certainly have in the recent past, of being too fixated on the detail of the message and forgetting who are our intended audience and what's the outcome we're trying to achieve with this. We probably ended up with a bit of a compromise of let's get reach first and foremost, and if that means let's not bastardise the message, but if we have to make some compromises to make sure that that people understand it, they get it, it resonates, then we've done a lot of that.
Brilliant, brilliant. And were there messages that resonated with you guys and that you're on board with?
Absolutely, and I think I try and pull just what Richard said and link it back to what Lorimer said beforehand in terms of this is not about someone else, this is about you. And all of those messages, I think one of the big challenges on top of reach will be thinking about how the listener, wherever they are, whether they're looking on the internet or whether they're sitting in one of those events, thinks actually this is about me. And I think the language we use there, it needs to be done as cleverly as we can. So at our group, we've looked at this, we've done a number of qualitative studies to try and see what are the experiences people have of going through pain neuroscience education, what do they think of it, and what are their thoughts, opinions, beliefs, understandings afterwards. Do they change? How do they change? And the data suggests that it is those people who believe the message is relevant to them. Those are the people who seem to benefit. If they don't think it's relevant, they don't seem to improve. They don't seem to move forward. And I think in order to make these key messages work, we have to use all the scientific literature we can to kind of say, right, now we just need to shape these and pass these on in as clever a way as we can. I think one of the clever ways we need to do it is by helping people to think, this is about me, it's not necessarily about other people.
And as you say, there's 6 messages you are hoping to capture a lot within that, so that sounds good.
Yeah.
Yeah, and I noticed deliberately today with the support of these guys with a 90-minute event today, largely we were trying to do the main part of delivery in 60 minutes, and there was a very conscious and deliberate decision on which you largely led on, Lorimer, which is 6 is too many for that. Let's pick a few of them, and it's a lot of it is just about capturing the imagination or planting the seed of doubt or getting people inquisitive, isn't it?
Yeah, I think so. I mean, we've got a fairly large sort of diversity of research that's led us to these sort of 9 key themes, 6 of which is a part of Flippin Pain. Yeah, and I think we decided we went for 3 today with the hook at the end, which was recovery as possible. But I do think that if you go back to your original question, Felicity, that there might be a physio who's thinking, I want to run a fortnightly pain education class, and I would say sit down beforehand and work out what do you want people to know, and if you've got more than half a dozen, halve it. And you can do a different class next week or whatever, but hammer it home, and in each scenario, trigger the action on it. Make people imagine things, reflect on things, monitor their own body. I mean, I'm learning a lot about learning at the moment, and it's such a privilege to have close contact to David Butler still in my life, because he is right on top of this stuff, and as a result of those sort of interactions, we're now saying to people, whether it's a group of health professionals or a group of patients, and you put in the confrontational message, which might be that pain never is a marker of tissue damage, which is hurt doesn't equal harm. And then we say to people, what's happening right now for you? What's happening in your body right now? Are you feeling a bit of tension? Are you feeling a bit of discontent about that? That means you're responding to this information. That means we've violated an expectation. That means you're making a journey. You've taken a little step. So there's a lot of this. It's called self-regulated learning, and I'm by no means an expert on it. But Dave is, and I get to have breakfast with Dave every week. So I really do think that's going to transform health education, not just pain education, because we have been lousy educators, and I should say I have been a lousy educator, and with that lousy education we've had some great outcomes. So imagine what happens when we become good educators.
So we recently published a systematic review. When I say we, it was mostly my PhD student Jamie Watson, and I was kind of hanging on at the side. But it was a mixed methods review, so it had quantitative and qualitative studies involved, and it looked at combining the information from the two. The qualitative stuff was really about trying to understand how should this be delivered. What's kind of the feedback in terms of how best it might be delivered, and we then looked to see how many of the RCTs we included actually delivered in that way, with all those bells and whistles, doing all the things it looks like you should do to make this work. And out of the list of 5 or 6, like 1 or 2 of them did 1 or 2. So in other words, I think when we're within the literature, and we've both delivered sort of PNE type RCTs, I think we probably haven't delivered them as well as we might have, but you can only learn that kind of in hindsight. I think if we did all the bells and all the things we now know about how we should be delivering it, went back and did those RCTs now, I think we might see a greater effect.
What was the point you made, Lauren, that was linked with that, wasn't it? Which was about It's not the intervention that you were suggesting as the effect, it's the learning as the effect. So you're sort of clearly differentiating from it. It's not just about delivering PNE, it's about if the learning, the reconceptualisation of learning has taken place is what your data is supporting.
Yeah, I think it's down to about 25 RCTs, I think, testing some version of pain education, contemporary pain education. I think the data are pretty clear that it's a good thing to do, but it's not a great thing to do. And there's a bit of hit and miss. The data that you're talking about is the audit data from the clinical practices that I've been involved with for sometimes almost 1,500 people. And that's not an RCT, right? But what those data show is that when there is a, and to use this language, there is a flipping of the understanding of pain, these people are highly likely to have a very good outcome. And when there's not a clear flipping, those people are highly likely to not have a very good outcome. But that does not say that explaining pain or PNE or is effective, because everyone in that cohort got that treatment.
Yep.
Now we can't randomly allocate people to understanding or not, so that's the limitation of the argument. We can't talk about an effect size of understanding. But what we can say is that whether it's causative or not, it's clearly associative that if people's understanding of pain is flipped into this unified human biopsychosocial protective output and the system learns, you can retrain the system, then they're on a different trajectory. And in a year's time, those trajectories are leaving people in very different places. But only half of them, in our data, only half of them do it. And I would say that in that cohort, every single clinician is delivering what we thought was good, top-notch pain education, and what we now think was really slick pain lectures. And now the excitement for me is flipping it to say we're not budging until you learn it, and you got to learn it. You're the one who's going to learn. Are you in? Are you going to do that? How are you going to do this? So it's a real flip of the whole culture and the whole posture of pain education from a delivery. Bam, bam, bam. You know, I'm the expert. Here you go. Here it is. And open up your brain and stick explain pain in and all this sort of stuff. And I was, I sort of had that posture when I started this journey. And the reason I apologise for it is not that it was malicious, but it was pretty naive. And the data are built up to say, man, all this stuff that we can do to promote learning. And sometimes I think we can get the key learnings from an experience where we violate the expectation carefully, kindly, with empathy, and we don't have to do any pain education. So I'm talking about that in a clinical environment. But back to the idea of an education-based public health campaign, I can see no better way to improve outcomes, reduce burden on the healthcare system, than to convince people before they're in the need for it that they are a resilient, unified human with the resources to cope after insult. And I think they can learn a lot of critical factors for anyway.
Brilliant. I think one of the barriers possibly to, a band 6 or a band 7 physio putting on a community pain, community centre doing this education seminar, probably illustrated by, you read on a media article, someone a very sensible account of why potentially back surgery isn't so great or the role pain really has. And you scroll down and you get to the comments, and there's a lot of, sometimes very understandably, people living with a lot of anger or frustration who live with pain, often justifiably so. So there's lots of people living with, often understandably, anger or frustration who live with persistent pain. Have you come across this within your sessions to people with pain, and how do you get around that? How do you diffuse a situation? How do you best manage that?
I'll go and throw that one to you.
Well, yeah, this is such an important question, and I don't know the answer to that question. I could just really say this is what I do, and this is what I think is important. This is what we train our people who are local pain educators to do it. And I think the first step is to make sure you know yourself. Make sure you understand what it is you want to achieve, and I think the most important posturing or position to be in when you receive an angry, accusatory or frustrated or really depressing input is your posture is defined by respect for that person and kindness and honesty. And I think that if you can carry that off, but it's a real internal sort of a thing, I think there's almost no interaction that if you're authentic in that, will escalate. However, having said that, you do get them. I've had people who are very unwell, and we've had escorted by police, and so that did escalate, and I didn't manage that well, and I think some of those occasions have been about me lacking some kindness or some respect, and at least one I can think of was I would interpret that there was no sense of reality in this person's life, so they were in a delusional state. So sometimes that'll happen, and I don't think we should beat ourselves up about that. But I also feel like, and maybe it's empathy, I often think in visual stuff. Whenever anyone's asking me a question in that context, what I want to do is I want to go and sit with them and feel where that question's coming from, and be with them in it. And I think if we don't think we've got to have the answers for all of this, if we just think, I want to try and understand that, and if the answer to if the question comes out and you don't have an answer, I just feel like, man, that's a really hard one. I don't have an answer. That must be a horrible situation to be in. Does that make sense? But I know there are strategies, and negotiators have this, and crisis counsellors have these sort of strategies to take people out of a really dangerous zone. I haven't learned those things, but I think most stuff is covered when you're sure of yourself. You as I said before, content knowledge is right, but you're just sure of yourself, and you say, well, I'm just going to be me. I don't have to be something that I think this person wants me to be, because you're going to misjudge that anyway. And then respect, kindness, I think, and honesty, I think.
Can I add a bit because if we're thinking about people trying to deliver these things, I think it's important that we've been on a bit of a journey with this. So in terms of the operational, logistical part of event management, I think for any of your frontline clinicians out there who are thinking of delivering this, you need to do some due diligence, have a team of support around you. So for example, we've learned about thinking really carefully about how the event or the talk that you're giving is billed and marketed, managing the expectations of the people before they arrive. You can be proactive in terms at the outset of delivering the event, in terms of having people support around you. You may be in a position where you can look at who's coming to the group beforehand, if you have sign-ups or if they're already in the system clinically, because even if you manage expectations and paint a picture of what people are coming to, are they coming voluntarily or not, you can often, we've been in positions where we've had some, we might say agitators or some resistance and stuff that's been challenging for the presenters to manage. And most of the time we could have seen that coming, and we could have dealt with it to the advantage of everybody involved, because if people are coming and you can't answer their concerns or their grievances beforehand, but you can, in the event, but you can identify that you may need to, you can look at what a different way of dealing with this person's questions or concerns be appropriate. And I would seek that support for you if you're presenting as well. So we made a bit of a deliberate attempt, particularly for our guest presenters. I mean, we kind of work on some assumption that you two guys are pretty hard and experienced and have dealt with this sort of thing, but we bring members of the general public or people with lived experience to join a Q&A panel. And we need them to feel empowered to say, I'm really sorry, that's not a question I can answer, and not let them, if they're giving up their time and not contributing very valuably to what we're doing, to the whole experience, we need them to feel that they can just say, that's not me, and for them not to feel vulnerable if they're on the receiving end of some challenging questions.
Yeah.
And that patient involvement in this whole Flippin Pain initiative is hugely, hugely important, because we are trying to educate and empower members of the public, and that is really harnessed if the message is coming from, for want of a better word, one of your own, someone who you can relate to, that you feel empowered by them having been empowered, if you know what I mean. So I think that's a really nice aspect of Flippin Pain, and something I hope that grows within it, that patients are very much at the heart and centre of it.
Brilliant. To finish up, I wondered if I could pick your brains about what you think we could or should be doing as clinicians within our own communities. Should we be writing to our CCGs or our MPs or booking church halls and things like that? What would you recommend, and what have you seen happen? What can we be doing in terms of delivering this message more publicly?
I guess that's uncharted territory for me. I guess I've never really thought about engaging in a public health campaign until Richard knocked on my door and said, have you considered doing, I said, have you checked out what Lorimer's doing? I went, oh, well, that was pretty impressive. I knew you did some cycling. But beyond that, I hadn't really, we're all in our own little silos. We're all doing our thing and trying to, and it's only when things like this come along that you lift up your head and you go, that looks like a really good idea, and it can kind of change you in a different direction. So I'm very new to this, but I think things like, just as you've suggested, seeing if you can engage local public involvement, whether it's your parish council or your local county council, whatever like that. If you really want to make a difference, was it Gandhi who said, be the difference you want to see in the world? I guess that's what we're trying to go for. But I was certainly in my own little silo, but something like this is kind of shaking me out of it a bit, which is, well, thanks to these two guys here, so yeah, wonderful.
Yeah, I mean, just practical stuff, so I'm a little bit biased or blinkered to thinking of UK-based physios, because that's where my background is. There isn't, there certainly shouldn't be any resistance to, or any lack of appetite for a desire, whether it's from a commissioner or a service provider, to want to better engage with the public outside of that. I think if we're working in systems that have a mindset of only being interested in influence the footfall that comes into their service or through their clinic door, then I think we're missing a massive trick. So I think there's tapping into what is the, I don't want to go too businessy, it's almost like your return on investment, because practically you're going to have a timetable or a clinical caseload, and you probably aren't sitting there with a couple of days a week free to design an event, market event, and then go and deliver an event and pull a crowd. But if you can loosely consider and prepare what are going to be the benefits to this, what's going to be the benefits to the local patient population, but then you need to think in sort of terms of what's going to be the benefit to the service or the system that I work in, the wider health economy. You've got to sort of tap into, which Lorimer's guys have been fantastic at doing, you've got to find the different hook for the different stakeholders that you need involved to support this. That's all before you actually go and deliver it. But and you're not going to do it as just a lone crusader, wherever or however you're doing it. You need a team.
Yeah, I concur with all that, and I think you mentioned the physio working in the corner shop physio practice, I think it is important to develop relationships with people you can get a hold of who share your willingness to be at the vanguard of implementing best practice and bringing science into care, because you'll feel lonely if you're the only one in your orbit. And a big part of Pain Revolution is supporting clinicians who are driving this change with formal communities of practice and resourcing them and just checking in how you're doing. But I also think we can, depending on what you like doing and what your contacts are, as Richard said, we put a lot of emphasis on collaboration and mutual need meeting. What is it the organisation needs, and maybe I can help deliver that. And pain's amazing and got great opportunity. Do you want to know more about that? Yeah, well, that journey starts, but right down to around the barbecue. Be bold. Be bold in your conversation. When someone you either know or you don't know, how are you? Oh, not too good, I've slipped a disc. Don't let it go. Don't let it go through the keeper. Be bold in what you know and be kind and honest and respectful. To say, that's a scary diagnosis. Do you know much about a disc? I'm amazed by discs. Because you know they can't actually slip. And take that opportunity to be accountable to what you know. Right from the barbie to the practice in service to the GP referral, be bold with kindness.
Talking about at parties, so whenever we go to a party, like my wife Helen will just kind of come along, kind of pass by. You're talking about pain again, aren't you? Yeah, sorry about that. I can remember once when I had our first child, and carrying her around, and we were at a party, and we were talking again, and then the subject got on to pain, as it always does. As you say, try and engage in that, and then all of a sudden I just felt this sudden heaviness, and my daughter had fallen asleep. As soon as I started doing it, she's like, oh no, Dad's talking about pain again.
She knows it all the way.
There you go, absolutely. But yeah, you're right. Every single time, I guess it's because we enjoy and we're interested in it. But it is about trying to pass that on at every opportunity.
I think it's mainly physios that I think are on this. I feel a bit safer with what I'm about to say. But I do think that the reality is in the pain clinical science field, it's physios who are at the leading edge of this. Maybe they're not alone, but they are at the leading edge of this. And I think physios can still suffer from this sense of it's not my place to claim knowledge or something like that. And I would say actually it is. There are people who have led physiotherapy to the front line over the last 30 years, and we owe them great debt, I think. We're respected as scientifically based good thinkers driving positive change, but let's not shirk that when we have these other conversations, and almost hold it with pride, but always with respect, kindness and honesty.
Brilliant. I think an empowering message to end on. I'd like to thank all three of you for not only your time but for sharing all the knowledge that you have and the things that haven't gone wrong as well. I think that's where we all learn the most from. So thank you so much.
Thank you.
Thanks for listening.
Thanks.
Thanks.